Everyone, welcome to the video lecture for Unit 3, Module 7.4. In this one, we're going to talk about a short introduction to gas exchange and then get into pulmonary ventilation. As always, here are your learning objectives. Please reference these when studying for both your lecture quiz and the unit exam. Let's go ahead and get started. So the general term respiration includes two integrated processes, external respiration and internal respiration. The definitions of these terms vary among references. In our discussion, external respiration includes all of the process involved in the exchange of oxygen and carbon dioxide between the body's interstitial fluids and the external environment. The purpose of external respiration and the primary function of the respiratory system is to meet the respiratory demands of cells. Internal respiration is the absorption of oxygen and the release of carbon dioxide by those cells. Our discussion here focuses on three integrated steps in external respiration. One is pulmonary ventilation, or breathing, physically moving air in and out of the lungs. Two is gas diffusion across the respiratory membrane between the alveolar air spaces and the alveolar capillaries, and across capillary walls between blood and other tissues. And three, the transport of oxygen and carbon dioxide between the alveolar capillaries and the capillary beds and other tissues. Abnormalities affecting any of these steps involved in external respiration ultimately affect the concentration of gases in the interstitial fluids, and thus cellular activities as well. If the oxygen level declines, the affected tissues will become starved for oxygen. Hypoxia, or low tissue oxygen levels, places severe limits on the metabolic activities of the affected area. For example, the effects of coronary ischemia result from chronic hypoxia affecting cardiac muscle cells. If the oxygen supply is cut off completely, the condition called anoxia results. Anoxia kills cells very quickly. Much of the damage from strokes and heart attacks results from local anoxia. Pulmonary ventilation is the physical movement of air in and out of the respiratory tract. Its primary function is to maintain adequate alveolar ventilation, movement of air in and out of the alveoli. Alveolar ventilation prevents the buildup of carbon dioxide in the alveolar. It also ensures a continuous supply of oxygen that keeps pace with the absorption by the bloodstream. Some basic physical principles govern the movement of air. One of the most basic is the weight of Earth's atmosphere compresses our body and everything around us. This atmospheric pressure, or ATM, has several important physiological effects. For example, air moves in and out of the respiratory tract as the air pressure in the lungs cycles below atmospheric pressures and above atmospheric pressures. The primary differences between liquids and gases reflect the interaction among individual molecules. The molecules in a liquid are in constant motion, but they are held closely together by weak interactions, such as the hydrogen bonding between adjacent water molecules. Yet because the electrons of adjacent atoms tend to repel one another, liquids tend to resist compression. If you squeeze a balloon filled with water, it will change into different shape, but the volumes of the two shapes will be the same. In a gas, such as air, the molecules bounce around as independent objects. At normal atmospheric pressure, gas molecules are much farther apart than the molecules in a liquid. The forces acting between gas molecules are minimal because the molecules are too far apart for weak interactions to take place, so an applied pressure can push them closer together. Consider a sealed container of air at atmospheric pressure. The pressure exerted by the gas inside results from the gas molecules bumping into the walls of the container. The greater the number of collisions, the higher the pressure. You can change the gas pressure within a sealed container by changing the volume of the container, giving the gas molecules more or less room in which to bounce around. If you decrease the volume of the container, pressure increases. If you increase the volume of the container, pressure decreases. For a gas in a closed container and at constant temperature, pressure, or P, is inversely proportional to volume, or V. That is, if you decrease the volume of a gas, its pressure will increase. If you increase the volume of a gas, its pressure will decrease. In particular, the relationship between pressure and volume is reciprocal. If you double the external pressure on a flexible container, its volume will drop by half. And if you reduce the external pressure by half, the volume of the container will double. This relationship is called Boyle's law, because it was first recognized by Robert Boyle back in the 1600s. Air flows from an area of higher pressure to an area of lower pressure. This tendency for directed airflow plus the pressure-volume relationship of Boyle's law provides the basis for pulmonary ventilation. A single respiratory cycle consists of inspiration, or inhalation, and expiration, or exhalation. Inhalation and exhalation involve changes in the volume of the lungs. These volume changes create pressure gradients that move air into or out of the respiratory tract. Each lung is surrounded by a pleural cavity. The parietal and visceral pleurae are separated by only a thin film of pleural fluid. The two membranes can slide across one another, but they are held together by that fluid film. You can see the same principle when you set a wet glass on a smooth tabletop. You can slide the glass easily, but when you try to lift it, you feel considerable resistance. As you pull the glass away from the tabletop, you create a powerful suction. The only way to overcome this is to tilt the glass so that air is pulled between the glass and the table, breaking the fluid bond. A comparable fluid bond exists between the parietal pleura and the visceral pleura, covering the lungs. For this reason, the surface of each lung sticks to the inner wall of the chest and the superior surface of the diaphragm. Movements of the diaphragm or rib cage that change the volume of the thoracic cavity also change the volume of the lungs. The diaphragm forms the floor of the thoracic cavity. The relaxed diaphragm has the shape of a dome that projects superiorly into the thoracic cavity. When the diaphragm contracts, it tenses and moves inferiorly. This movement increases the volume of the thoracic cavity, decreasing the pressure within it. When the diaphragm relaxes, it returns to its original position, and the volume of the thoracic cavity decreases. Due to the nature of the articulations between the ribs and the vertebrae, superior movement of the rib cage increases the depth and width of the thoracic cavity, increasing its volume. Inferior movement of the rib cage reverses the process, decreasing the volume of the thoracic cavity. At rest, just prior to inhalation, pressures inside and outside of the thoracic cavity are identical, and no air moves in or out of the lungs. When the thoracic cavity enlarges, the lungs expand to fill the additional space. This increase in volume decreases the pressure inside of the lungs. Air then enters the respiratory passageways because the pressure inside the lungs is lower than the atmospheric pressure outside. Air continues to enter the lungs until their volume stops increasing and the internal pressure is the same as that of outside. When the thoracic cavity decreases in volume, pressures increase inside of the lungs, forcing air out of the respiratory tract. The compliance of the lungs is an indication of their expandability, or how easily the lungs expand. The lower the compliance, the greater the force required to fill the lungs. The greater the compliance, the easier it is to fill the lungs. Factors affecting compliance include the following. 1. The connective tissue of the lungs. The loss of supporting tissues due to alveolar damage, as in emphysema, increase compliance. This loss results in the alveoli increasing beyond their normal size, making the lungs easier to fill. 2. The level of surfactant production. On exhalation, the collapse of the alveoli due to inadequate surfactant, as in respiratory distress syndrome, reduces compliance. And 3. The mobility of the thoracic cage. Arthritis or other skeletal disorders that affect the articulation of the ribs or spinal column also reduce compliance. At rest, the muscular activity involved in pulmonary ventilation accounts for 3 to 5% of the resting energy demand. If compliance is reduced, that figure climbs dramatically. An individual may become exhausted simply trying to continue breathing. To understand the mechanics of respiration and the principles of gas exchange, we must know the pressure inside and outside of the respiratory tract. We can report pressure readings in several ways. We use millimeters of mercury, as we did for blood pressure. Atmospheric pressure is also measured in atmospheres. At sea level, 1 atmosphere of pressure, or 1 ATM, is equivalent to 760 millimeters of mercury. The direction of airflow is determined by the relationship between atmospheric pressure and the interpulmonary pressure. Intrapulmonary pressure, or intra-alveolar pressure, is the pressure inside the respiratory tract of the alveoli. When you are relaxed and breathing quietly, the difference between atmospheric pressure and intrapulmonary pressure is relatively small. On inhalation, your lungs expand, and the intrapulmonary pressure drops to about 759 millimeters of mercury. Because the intrapulmonary pressure outside is 1 below the atmospheric pressure, it is generally reported as 21. On exhalation, your lungs recoil, and intrapulmonary pressure rises to 761, or plus 1. The size of the pressure gradient increases when you breathe heavily. When a trained athlete breathes at maximum capacity, the pressure differentials can reach 230 millimeters of mercury during inhalation and 1100 if the individual is strained with the glottis kept closed. This is one reason you are told to exhale while lifting weights. Exhaling keeps your intrapulmonary pressures and peritoneal pressures from increasing so high that an alveolar rupture or a hernia could occur. Intrapleural pressure is the pressure in the pleural cavity between the parietal and visceral pleurae. Intrapleural pressure averages about 24. During a powerful inhalation, it can reach up to about 218. This pressure is below atmospheric pressure due to the relationship between the lungs and the body wall. Earlier, we noted that the lungs are highly elastic. In fact, they would collapse to about 5% of their normal resting volume if their elastic fibers could recoil completely. The elastic fibers cannot recoil so much, however. The reason is that they are not strong enough to overcome the fluid bond between the parietal and visceral pleurae. The elastic fibers continually oppose that fluid bond and pull the lungs away from the chest wall and the diaphragm, lowering the interpleural pressure slightly. The elastic fibers remain stretched even after a full exhalation. For this reason, interpleural pressure remains below atmospheric pressure throughout a normal cycles of inhalation and exhalation. The cycle changes in the interpleural pressure create the respiratory pump that assists the venous return to the heart. A respiratory cycle is a single cycle of inhalation and exhalation. At the start of the respiratory cycle, the interpulmonary and atmospheric pressures are equal and no airflow is moving. Inhalation begins with the fall of interpleural pressure and takes place when the thoracic cavity expands. This pressure gradually falls from approximately 26. Over the period, intrapulmonary pressure drops to just under 21. It then begins to rise as air flows into the lungs. When exhalation begins, intrapleural and interpulmonary pressures rise rapidly, forcing air out of the lungs. At the end of exhalation, air again stops moving when the difference between intrapulmonary and atmospheric pressures has been eliminated. The amount of air moved into the lungs during inhalation equals the amount moved out of the lungs during exhalation. That amount is the tidal volume. So as we've just seen, you move air into and out of the respiratory system by changing the volume of the lungs. Those changes alter the pressure relationships, producing air movement. The changes in volume in the lungs take place through the contraction of skeletal muscles, specifically those that insert on the rib cage, and the diaphragm, which separates the thoracic and abdominopelvic cavities. Because of the nature of their articulations with the vertebrae, when the ribs are elevated, they swing outwards, increasing the depth of the thoracic cavity. We can compare this movement to raising the handle of a bucket. We introduced the skeletal muscles that are involved in respiratory movements back in 168. Of those muscles, the most important are the diaphragm and the external intercostal muscles. Inhalation is an active process. It involves one or more of the following actions. Contraction of the diaphragm flattens the floor of the thoracic cavity, increasing its volume and drawing air into the lungs. Contraction of the diaphragm brings about 75% of the air movement in normal breathing at rest. Contraction of the external intercostal muscles assists in the inhalation by raising the ribs. And this action contributes to approximately 25% of the volume of the air in the lungs at rest. And then contraction of accessory muscles, including the sternocleidomastoid, the serratus anterior, the pectoralis major, and the scalene muscles, can assist the external intercostal muscles by elevating the ribs. These muscles increase the speed and the amount of rib movement. Exhalation is either passive or active, depending on the level of respiratory activity. When exhalation is active, it may involve one or more of the following actions. The internal intercostal and the transversus thoracic muscles depress the ribs. This action reduces the width and depth of the thoracic cavity. The abdominal muscles, including the external and the internal obliques, the transversus abdominis, and the rectus abdominis muscles, can assist the internal intercostal muscles in exhalation by compressing the abdomen. This action forces the diaphragm upward. We use the respiratory muscles in various combinations, depending on the volume of air that must be moved in or out of the system. We usually classify respiratory movements as quiet breathing or forced breathing according to the pattern of muscle activity during a single respiratory cycle. In quiet breathing, or eupnea, inhalation involves muscular contractions, but exhalation is a passive process. Inhalation usually involves contracting both the diaphragm and the external intercostal muscles. The relative contributions of these muscles can vary. During the diaphragmatic breathing, or deep breathing, contraction of the diaphragm provides the necessary change in the thoracic volume. Air is drawn into the lungs as the diaphragm contracts. Air is exhaled passively when the diaphragm relaxes. In costal breathing, or shallow breathing, the thoracic volume changes because the rib cage alters its shape. Inhalation takes place when contractions of the external intercostal muscles raise the ribs and enlarge the thoracic cavity. Exhalation takes place when these muscles relax. During quiet breathing, expansion of the lungs stretches their elastic fibers. In addition, elevation of the rib cage stretches opposing skeletal muscles and elastic fibers in the connective tissues of the body wall. When the muscles of inhalation relax, these elastic components recoil, returning the diaphragm, the rib cage, or both to their original positions. This action is called elastic rebound. We typically use diaphragmatic breathing at minimal levels of activity. As we need increased volumes of air, our inspiratory movements become larger and the contribution of rib movement increases. Even when at rest, costal breathing can predominate when abdominal pressures, fluids, or masses restrict diaphragmatic movements. For example, pregnant women rely more and more on costal breathing as the enlarging uterus pushes the abdominal organs against the diaphragm. Forced breathing, or hyperpnea, involves the active inspiratory and expiratory movements. In forced breathing, our accessory muscles assist with inhalation, and exhalation involves the contraction of the internal intercostal muscles. At absolute maximum levels of forced breathing, our abdominal muscles take part in exhalation. Their contraction compresses the abdominal contents, pushing them up against the diaphragm. This action further reduces the volume of the thoracic cavity. The respiratory system is extremely adaptable. You can be breathing slowly and quietly one moment, rapidly and deeply the next. The respiratory system adapts to meet the oxygen demands of the body by varying both the number of breaths per minute and the amount of air moved per breath. When you exercise at peak levels, the amount of air moving in and out of the respiratory tract can be 50 times the amount moved at rest. Your respiratory rate is the number of breaths that you take each minute. As you read the notes or you look at the chapter for this module, you're probably breathing quietly with a low respiratory rate. The normal respiratory rate of a resting adult ranges from 12 to 18 breaths each minute, roughly 1 for every 4 heartbeats. Children can breathe more rapidly at rates of about 18 to 20 breaths per minute. We can calculate the amount of air moved each minute and symbolize that as V sub E by multiplying the respiratory rates by the tidal volume. This value is called the respiratory minute volume. The respiratory rate at rest averages about 12 breaths per minute, and the tidal volume at rest averages around 500 milliliters per breath. On that basis, we can calculate the respiratory minute volume as follows, which is V sub E is equal to F times VT. So in other words, the respiratory minute volume at rest is approximately 6 liters per minute if we're looking at the figure here. The respiratory minute volume measures pulmonary ventilation. It provides an indication of how much air is moving into and out of the respiratory tract. However, only some of the inhaled air reaches the alveolar exchange surfaces. A typical inhalation pulls about 500 milliliters of air into the respiratory system. The first 350 milliliters of inhaled air travels along the conducting passageways and enters the alveolar spaces. The last 150 milliliters of inhaled air never gets that far. It stays in the conducting passageways and thus does not participate in gas exchange with the blood. The volume of air in the conducting passageways is known as the autonomic dead space, or denoted as VD. Alveolar ventilation, symbolized as V sub A, is the amount of air reaching the alveoli each minute. The alveolar ventilation is less than the respiratory minute volume because some of the air never reaches the alveoli, but instead remains in the dead space of the lungs. We can calculate alveolar ventilation by subtracting the dead space from the tidal volume. Basically, V sub A is equal to F times VT minus VD. At rest, alveolar ventilation rates are approximately 4.2 liters per minute. However, the gas arriving in the alveoli is significantly different from the surrounding atmosphere. The reason is that inhaled air always mixes with used air in the conducting passageways, so the autonomic dead space on its way in. The air in the alveoli thus contains less oxygen and more carbon dioxide than does atmospheric air. The respiratory minute volume can be increased by increasing either the tidal volume or the respiratory rate. In other words, you can breathe more deeply and more quickly, or both. Under maximum stimulation, the tidal volume can increase to roughly 4.8 liters. At peak respiratory rates of about 40 to 50 breaths per minute and maximum cycles of inhalation and exhalation, the respiratory minute volume can approach 200 liters per minute. In functional terms, the alveolar ventilation rate is more important than the respiratory minute volume because it determines the rate of delivery of oxygen to the alveoli. The respiratory rate and the tidal volume together determine the alveolar ventilation rate. For a given respiratory rate, the increase in the tidal volume, or breathing more deeply, increases the alveolar ventilation rate. For a given tidal volume, increasing the respiratory rates, or breathing more quickly, increases the alveolar ventilation rate. The alveolar ventilation rate can change independently of the respiratory minute volume. In our previous example, the respiratory minute volume at rest was 6 liters, and the alveolar ventilation rate was 4.2 liters per minute. If the respiratory rate rises to 20 breaths per minute, but the tidal volume drops to 300 milliliters, the respiratory minute volume remains the same. However, the alveolar ventilation rate drops to only 3 liters per minute. For this reason, whenever the demand for oxygen increases, both the tidal volume and the respiratory rate must be regulated closely. We exchange only a small proportion of the air in our lungs during a single quiet respiratory cycle. We can increase the tidal volume by inhaling more vigorously and exhaling more completely. We can divide the total volume of the lungs into a series of volumes and capacities, each the sum of various volumes. These measurements are obtained by an instrument called a spirometer. Spirometry values are useful in diagnosing problems with the pulmonary ventilation. Adult females on average have smaller bodies and thus smaller lung volumes than do males. As a result, there are sex-related differences in respiratory volumes and capacities. Pulmonary volumes include the following. The tidal volume is the amount of air you move in or out of your lungs during a single respiratory cycle. The tidal volume averages about 500 milliliters in both males and females. The expiratory reserve volume, or the ERV, is the total amount of air that you can voluntarily expel after you've completed a normal, quiet respiratory cycle. As an example, with maximum use of the accessory muscle, males can expel an additional 1,000 milliliters of air on average. Female expiratory reserve volume averages around 700 milliliters. The residual volume is the amount of air that remains in your lungs even after a maximal exhalation, typically around 1,200 milliliters in males and 1,100 milliliters in females. The minimum volume of a component of the residual volume is the amount of air that would remain in your lungs if they were allowed to collapse. The minimum volume ranges from 30 to 100 milliliters. Unlike other volumes, it cannot be measured in a healthy person. The minimal volume and the residual volume are very different because the fluid bond between the lungs and the chest wall normally prevents the recoil of the elastic fibers in the lungs. Some air remains in the lungs, even at minimal volume, because the surfactant coating of the alveolar spaces prevents their collapse. The inspiratory reserve volume, or the IRV, is the amount of air that you can take in over and above the tidal volume. On average, the lungs of males are larger than those of females. And for this reason, the inspiratory reserve volume of male averages about 3,300 milliliters compared to 1,900 milliliters in females. We can calculate respiratory capacities by adding the values of various volumes. Examples include the following. The inspiratory capacity is the amount of air that you can draw into your lungs after you've completed a quiet respiratory cycle. The inspiratory capacity is the sum of the tidal volume and the inspiratory reserve volume. The functional residual capacity, or the FRC, is the amount of air remaining in your lungs after you've completed a quiet respiratory cycle. The FRC is the sum of the expiratory reserve volume and the residual volume. The vital capacity is the maximum amount of air that you can move into or out of your lungs in a single respiratory cycle. The vital capacity is the sum of the expiratory reserve volume, the tidal volume, and the inspiratory reserve volume. It averages around 4,800 milliliters in males and 3,400 milliliters in females. The total lung capacity is the total volume of your lungs. We calculate it by adding the vital capacity and the residual volume. The total lung capacity averages around 6,000 milliliters in males and 4,200 milliliters in females. Pulmonary function tests monitor several aspects of respiratory function by measuring these rates and volumes of air movement.